Our speaker, Paul Moore. Paul currently serves in Washington, D.C. as Senior Health Policy Advisor to the Federal Office of Rural Health Policy. To this opportunity, he brings a lifetime of experience related to rural healthcare from both his family heritage and more than 30 years in the community and hospital pharmacy. But his career reaches beyond just pharmacy, as he has served as the CEO of a county healthcare authority consisting of one of the nation's earliest critical access hospitals, the county EMS, a physician clinic, and a home health agency, an opportunity which served him well as the 2008 president of the National Rural Health Association. And now in his day job, where he has the opportunity to work with critical access hospitals and other rural providers across the nation around issues of quality improvement and patient safety. Now, I'll turn it over to Paul.
Well, thank you so much, Kim, and thank you everyone for taking the time out of your day to join this webinar. I appreciate you being with us. I know that you have other things you could be doing, but so I hope to make good use of your time and to, as we discuss this issue of rural relevant measures and where we go with that. As we discuss today's topic, I want to begin by acknowledging that the burden of measuring and reporting the quality of care provided in our rural hospitals is a majority of the time borne by the same folks who are diligently providing that care. But I also want to discuss why quality reporting is so important. And also acknowledging that such a discussion should be placed within the real-world context of the issues being faced by rural hospitals. There are emerging national priorities and strategies and the challenging environment in which we find ourselves. We will look at some principles to guide the selection of measures that are appropriate and meaningful to rural providers and patients. And we will look at some current initiatives underway informing the process and moving us into action. So why measure and report quality? Well, first and foremost, healthcare providers want to provide the most appropriate, highest quality, safest care possible every single time. Tracking the right measures give providers a way to know to what extent we are consistently achieving this goal and where there is room for improvement. And the transparency of reporting holds us accountable to make those needed improvements systematically because every patient matters. You know, but it's also about human nature. We tend to measure what we value, and usually with the hopes of increasing it. And measuring the quality of care we provide affirms that we aren't just talking quality and safety, but that it's a core value, and we are working to improve it. Some rural providers are required by regulation to report to sites such as Hospital Compare or the Physician Quality Reporting System, but CMS quality improvement programs systematically exclude many hospitals and clinicians who provide care in rural areas. So why would rural providers who are exempt want to do what is not required? Well, the answer is we need to tell our own quality story, and the way you do that is with data. And now on the horizon, there may be another reason. You see, healthcare performance measures increasingly are being used by both public and private purchasers and insurers for various types of accountability applications, including accreditation, network inclusion or exclusion, public reporting, and payment incentive programs. And measuring and reporting quality is core to this national momentum. The Affordable Care Act mandated the creation of a national strategy for quality improvement in healthcare. And it had three objectives for healthcare quality improvement: better care, better health, and less cost. To achieve these objectives, the National Quality Strategy identified the following 6 priorities: reducing harm to patients, facilitating communication and care coordination, empowering patients and families to be involved in their care, implementing evidence-based prevention and treatment, promoting healthy behaviors and environments at the community level, and implementing new delivery models that reduce cost and improve quality. Now, together, these objectives and priorities serve as the blueprint for healthcare performance measurement in the United States. And HHS has coupled the CMS quality improvement programs and the CMS payment levers, such as payment adjustments, bonuses, and penalties, to move the U.S. healthcare delivery system toward this reformation, with the conviction that improving the way providers are paid, the way care is delivered, and the way information is distributed will get us to better care, smarter spending, and healthier people system-wide. Back on January 26th, HHS Secretary Sylvia Burwell announced a major initiative focused on healthcare delivery system reform. The announcement included measurable goals and a timeline to move the Medicare program and the healthcare system at large toward paying providers based on quality rather than the quantity of care that they give patients. This initiative will have important implications for all healthcare providers and the patients they serve, including rural. When it comes to improving the way providers are paid, the idea is to reward value and care coordination rather than volume and care duplication. In other words, to promote value-based systems that pay providers for what works, including linking Medicaid, Medicare fee-for-service, and other payments to value. These and other models are already being tested as important approaches for improving care and lowering costs, and some are already seeing some positive results. To improve care delivery, models are moving providers toward finding new ways to coordinate and integrate clinical services. There is also a focus on improving the health of our communities with a priority on prevention and wellness. Better care coordination can also mean giving patients more quality time with their doctor, expanding the ways patients are able to communicate with a team of clinicians taking care of them, or engaging patients and family more deeply in decision making. And as we look at the way to improve the information is distributed, HHS is working to create more transparency on the cost and the quality of care, working to bring electronic health information to inform care, and to bring the most recent scientific evidence to the point of care to bolster clinical decision making. Now, looking at this slide, you will note that it's much the same information that we just looked at, but with a couple of important additions: goals and timelines. And you will likely notice a couple of things. First, that the goals and timelines are aggressive. It's almost like the Secretary has said, warm-up is over, and it's time to get the folks in the game. And if you happen to be familiar with the rural percentage of the total Medicare spend, you'll notice, secondly, that you could actually leave small rural providers out of the mix and still reach the goals that are set. So that begs the question, would that be a good thing or a bad thing? Do we want a two-tiered system where rural is left out of where health reform is headed? Or are you concerned that being excluded may lead to irrelevance? If so, how do rural providers engage? Well, if we're talking about a goal of having half, 50% of all Medicare payments under an alternative payment model by 2018, here are some of the alternative payment models that already exist. There's things such as multiple versions of accountable care organizations. But when you look at where these models are emerging, you will see that there is a lagging of penetration into rural areas, and fewer small rural providers are being engaged. One possible reason for that is that these accountable care organization models are value-based. And how do you measure the value of a small rural provider beyond the issue of them being there, the issue of access? How do you measure the value if there's little or no quality data to examine? The current reality is a large proportion of the hospitals, clinics, and clinicians that are excluded from the CMS quality programs operate in rural areas. Therefore, many care providers serving rural communities cannot participate in these programs and thus do not receive the financial incentives and comparative performance data that are provided through the programs for the purpose of spurring improvement. Now, although program expansion for critical access hospitals is not imminent, the Affordable Care Act mandates a demonstration program to inform how CAHs can participate in the hospital value-based purchasing program. But this demonstration has not happened today. As CMS programs and policies evolve, however, more and more rural providers will be subject to pay-for-performance programs. For example, in 2015, only practices with 100 or more eligible professionals are included in the Clinician Value-Based Payment Modifier program. However, this program will be extended to all fee-for-service Medicare clinicians by 2017. But currently, that excludes rural health clinics and health centers that are paid under another methodology. And while some stakeholders desire the eventual participation of exempt rural providers in CMS quality improvement programs, including pay-for-performance programs, the very size of these small rural practices may pose significant measurement and design challenges for the various programs. So once again, it begs the question, do we want a two-tiered system where rural patients and providers are left out of where all the health reform is headed? And we're not just considering this question in some ivory tower setting. We are grappling with this question in a most dynamic, challenging environment. An environment where we are seeing changes in reimbursement methodologies, changes in our payer mix due to increased coverage, where Medicaid expansion is or maybe is not happening, changing dynamics in workforce with more employed practitioners, realignments, other new market forces at work, acquisitions, segmentation, closures, and an ever-increasing role for health information technology. The question is, what might such a transition mean for rural providers and the people they serve? We will also be trying to make this transition in a very challenging financial environment. You see, we already know that small rural hospitals, this would be including the tweeners up to 50 beds and critical access hospitals. These small rural hospitals generally have the lowest profitability in comparison to hospitals with other payment classifications. Now, while most of these challenges are not limited to rural areas, the impact on quality measurement and improvement likely is exacerbated in rural areas. But there's yet another aspect of this challenging environment that I want you to consider. An environment in which patients and purchasers will be looking for value. And reimbursement will increasingly be tied to quality. And the thing I want you to consider is just this. If we don't tell our own quality care story with rural relevant data, others will perform their own assessments with maybe perhaps less appropriate data, and they'll be more than happy to tell the story from their own perspective. It's not because of ill will on their part. They will just be going where the less relevant data leads them. So we need to be sure that development of any system for measuring value for rural providers takes into consideration some key rural issues and challenges that can negatively influence quality measurement or improvement activities. One challenge is in the area of limited human resources. Smaller rural hospitals and clinician practices often have limited time and staff available for activities such as data collection, analysis, and reporting. And those who serve in small practices often wear many hats, including direct patient care, personnel management, and operational responsibilities. Those activities compete with quality improvement activities. In many rural areas, there's a limited supply of individuals with the specialized training or skill sets, such as the ability to use electronic health records or registries for measurement and calculation, or even the quality improvement skills needed to use measurement results to drive improvements in care. In addition, lack of financial resources also impacts ability to invest in health information technology infrastructure that can facilitate quality improvement initiatives. Many rural providers may not offer a full suite of healthcare services. For example, some small hospitals or critical access hospitals may not do surgery or even have ICUs. And because of this, surgical measures used in many quality improvement programs may not be all that applicable. Also, there is always that small number issue. Many rural providers do not have enough patients to achieve statistically reliable and valid measurement results. Any system to measure and report the quality of services provided by small volume rural providers, especially if those measures will affect the payment for those services, must be guided by principles that will result in rural relevant measures. So let's look at just a few guiding principles for rural relevant quality measures. Now, and I want to say up front, I'm sure you will think of some that I've omitted. This is not an exhaustive list that I'm offering by any means, but these are some that I want to put out there, and I encourage you to think of others. Because many rural areas will have small sample sizes that will impact measure reliability, measures used for rural providers should be broadly applicable for most rural providers. And there's some examples that could be areas such as vaccinations, blood pressure control, diabetes control, medication reconciliation. These are the types of measures that would apply to a large proportion of patients served by rural providers. You could also employ strategies that address low-volume challenges, such as using ratio measures or timing measures, things like emergency department wait times, or the MV-QIP medication verification measure. Perhaps even consider rural solutions for existing measures, such as HCAHPS, reporting thresholds, and excluding patients that are discharged to nursing homes or hospice, activities that happen now that even further restrict the numbers that we're able to report. Measures should also allow for fair comparisons between providers. through appropriate case mix adjusted for things like demographic and social determinants, or through program policy such as establishing appropriate peer groups for comparison. Another guiding principle would be to consider measures that promote provision of care at the local level. Measures such as telehealth measures, timeliness of care, avoided transfers. Those situations where provision of local care will have a better quality outcome. Measures that could potentially hinder access to health care in rural communities should not be selected for use in quality improvement programs. Measures should also be supported by evidence, empirical evidence, demonstrating clinical effectiveness and desired outcomes. And then also measures should be actionable with the opportunity for improvement. Some activities such as triage and transfer may be more common among rural providers. So measure things such as the ED transfer communication measure. Because of resource constraints, measures selected for use with rural providers should rely on data that are readily available or at least feasible to collect. Because the primary goal of measurement is to improve the quality of care, measures selected for reporting should be useful in internal quality improvement efforts, not just for the sake of reporting upstream, but for the sake of improving quality at the local level. Measures used for public reporting should also be meaningful for consumers and purchasers who use the results for their decision making. Measures could be designed to demonstrate the level of patient and family engagement, and they should include patient satisfaction. Particularly relevant for rural providers with financial or staff constraints is that measures required by different programs be aligned so that related measures are not reported in 12 different ways to 12 different programs. So, with these key rural issues, objectives, and guiding principles in mind, I want to let you know that the serious work is underway at the National Quality Forum addressing performance measurement for rural low-volume providers. Back in 2014, the Department of Health and Human Services contracted with the National Quality Forum, you know them as NQF, in order to convene a multi-stakeholder committee to make recommendations to address challenges in healthcare performance measurement, including low case volume for rural providers. And they contracted to provide multi-stakeholder information and guidance on performance measurement issues for rural providers, including critical access hospitals, rural health clinics, community health centers, small rural PPS hospitals, small rural clinician practices, and even physicians who serve clinicians who serve in all these settings. The purpose of the project is to identify challenges in performance measurement of rural, low-volume providers and to make recommendations for mitigating these challenges, particularly in the context of pay-for-performance programs operated by CMS. The specific objectives of this project are to, one, make recommendations regarding measures appropriate for use in CMS pay-for-performance programs for rural hospitals and clinicians. Secondly, make recommendations to help mitigate measurement challenges for rural providers, including the low case volume challenge. And then also to identify identify and measure gaps for rural hospitals and clinicians. And the project includes an environmental scan of measures and measurement programs. You'll note the link on the slide to the information. Multi-stakeholder input on measurement efforts and challenges for rural providers, and a written report of committee recommendations regarding performance measurement for rural providers in the context of federal payment incentive programs. And there are some important dates in conjunction with this work at the NQF that I want you to put on your calendar. First of all, sometime between June the 1st and the 30th, a draft report will be available for public comment. So what I ask of you is that you be waiting for it, that you watch for it, that you review it when it becomes available, and you let your ideas and perspectives be heard on what the report is suggesting. Then, after all the comments are received and the comment period closes, on I think around July the 29th, there will be a committee web meeting to review and respond to the comments that are made. By the way, you know that all NQF meetings are open to the public. And then sometime around September, the final report will be due to the Department of Health and Human Services, I think on September the 14th. So for more information on this, there's a link on the slide that you can access. And you can also sign up for Project Alert emails to receive notifications of the upcoming meetings and activities around this project. And you can even contact the project team at ruralhealth@qualityforum.org. You know, the sponsor of our webinar today is the Small Rural Hospital Transitions Project, and they assist small rural hospitals in bridging gaps between the current healthcare system and the newly emerging system of healthcare delivery and payment, a system that will be based on value and reflected in improved performance and patient outcomes. Now, part of what they are doing through their technical assistance is providing small rural hospitals with help in creating that value through a quality-focused environment. And quality measurement and reporting is a huge part of that. But those quality measures in rural areas must be relevant to the resources we have and the populations we serve. That's why we here at the Federal Office of Rural Health Policy have reworked the priorities of Medicare Beneficiary Quality Improvement Project for this next fiscal cycle. And we're leveraging our resources and efforts to align with the national measures and priorities. We're focusing on rural relevant measures in 4 particular areas: patient safety, with a focus on adverse drug events, health system acquired infections and falls; patient engagement in their own care transitions, and outpatient measures. As you look at this honeycomb of activities, you know they say a picture's worth 1,000 words. Well, you're getting your 1,000 words anyway, but as you look at this honeycomb and the resources that are mentioned here across not only the Federal Office of Rural Health Policy, but across all of HHS, you'll notice that we are guided by work such as the National Quality Strategy, the National Action Plan for Healthcare-Associated Infections, the National Action Plan for Adverse Drug Events, and other things. We're supported by tools from the Centers for Disease Control and from AHRQ, and initiatives from CMS like the Special Project on ED Transfer Communication, the Partnership for Patients, and the Transforming Clinical Practice Initiative, and that we are aligning our grants and programs toward having the rural healthcare system of the future as logical participants in delivery system reform leading to better health, better care, and lower cost. Because, and I really believe this, the rural healthcare system of the future is essential to the entire healthcare system. The rural healthcare system of the future can provide integrated access to better care, better health, and lower cost. The rural healthcare system of the future will report on quality as one way to prove value to both patients and to purchasers. And final thought, the rural healthcare system of the future will find sustainability through value. The purpose, again, of the Small Rural Hospital Transition Project, by assisting small rural hospitals in bridging those gaps between the current healthcare system and the newly emerging system of healthcare delivery and payment, and the goal of the Federal Office of Rural Health Policy by encouraging small rural hospitals in rural relevant measure and reporting of quality is this: to help rural communities make that transition. So thank you for taking time out of your day today to participate in the webinar. Hopefully I've answered some questions that maybe, or hopefully I've raised questions. That would be the best outcome. To cause you to start thinking about this, to cause you to see what you're doing in your own community. But I thank you for considering what rural relevant measures might include. I thank you for being ready to comment when the opportunity comes, for watching for that NQF work to come out around June the 1st, and then taking the time to review and add your comments. Thank you so much. Kim, I'll turn it back to you.
Thank you, Paul. Does anyone have any questions? It looks like we have plenty of time left over. If you have a question, you can ask it by unmuting your line, *2, or you can type it in the chat box on the screen. Looks like Monica has a question. She's typing in the chat box. Maybe not. Does anyone else have a question? Paul, you mentioned that small rural providers could actually be left out of the delivery system reform and still reach the goals. Can you clarify?
Well, if you look at that chart that we saw, the goals, I think, are 90%. The total rural hospital spend, and maybe total rural spend, but at least I'm familiar with the hospital spend, is somewhere around 5%. So in that sense, you could miss all rural hospitals and delivery system reform and still meet that 90% goal. That's what I'm talking about.
Great. It looks like Monica's question. Paul, what recommendations do you have for critical access hospital CEOs to begin preparing for these changes?
Great question, Monica. I hope that most critical access hospitals are already being prepared because they're participating in programs like the Medicare Beneficiary Quality Improvement Project. Maybe they're reporting to Hospital Compare. Maybe they're involved in a system that helps them or has requirements, reporting requirements. You know, I don't think we're at ground zero. I don't think we're at the starting point. I think we're along the way. What I would say is that you begin to look, just because, as you know, certain payer types like rural health clinics and critical access hospitals, because we are not paid based on our quality measures, that we're not in getting some of these penalties that the PPS hospitals are encountering, things like that, to not think that, well, it's not important for us. As I said, it's important in so many ways. Number one, the first way, and that you're most aware of, is that it's important to the quality of care that we're providing, and to knowing that we're not satisfied with anything, we want to keep improving it, and we want to know. But number two, that when time comes, due to maybe an article coming out or to the day that our payment depends on it, that we have a quality story to tell, and we have the data to back up what we're telling, and that we found ways around the small numbers issue, that we found that we're reporting on the kind of business that we're doing, not the kind that we're not engaged in. So that would be my answer to your question, to make the case when the time comes while improving the quality along the way. Well, I'll go ahead and read what I'm looking at. Kathy says, what can health information exchange systems do to contribute to planning and data analysis for population health and hospital contribution to improving status? I tell you, the key to being able to pull all this off, because, I mentioned that folks in the smallest hospitals wear multiple hats, and it's hard to pull off of direct patient care in order to measure and document the care you're providing. So the more that can be automated in health information systems, the more that can be captured automatically, the more human workload that we can reduce because the technology is there to take up the slack, the better off it will be. Jill says, I was at a symposium last week, and one of the discussions was improvement fatigue. I've heard that, Jill. Hospitals are getting tired of measuring, so they don't get around to improving. Can you comment on this? Well, you've nailed what I just said in the previous answer, is these folks are being asked to do it all. And so some of the things we can do is make sure that they're not doing it all in 12 different directions, or, close but not same measures. We can do alignment. And that's something we're wanting to do here at the federal office, but it's something that needs to be done as we're considering any measures, especially if it comes to the point to where our payment is based on those in some way, because fatigue is real. And the most important thing that happens in a hospital or in a rural provider is the care of that patient. That is primary. But in order to be able to prove the care, the value that we're providing, we've got to follow up with that second step. So I'm sensitive to that issue of just being overwhelmed by all the things they're asked to do. I know that we can't pick or choose. We just have to prioritize. Susan says, we just completed the Small Rural Hospital Transitions Program, and it was extremely helpful to us. It provided us with direction for the future, and I would encourage all CEOs to take advantage of this opportunity. Thank you for that testimony, Susan. We appreciate it. Amber says, we are currently doing some benchmark reporting on ambulatory measures. I am looking for the national and state benchmark reports. There are a few on AHRQ, but for our state in Montana, there are not many results. Do you have baselines for rural areas? Great question. Amber, those baselines, I think we're all looking for those. That's why we're actually even at the office here, even trying to establish some. And so I guess what I would say is get creative in the way you look for those baselines, how you look for them. It's not a perfect system by any means, but we're trying to do that across states and across the entire nation for critical access hospitals. Those benchmark reports, if they're not out there, we need to be about creating them and building them, because you don't just create them and they exist. You actually have to build them. So thank you for that question. And then there may be folks on the call today that can also get you a direct answer to where they know where some of those baselines are. Other questions?
Looks like Kathy has another question she's typing in. If anyone else wants to speak, it's *2 to unmute your line. Paul, it seems like this whole idea of delivery system reform is asking the rural provider to find ways to save the system money by reducing their already low volume services even more. How can we do that and still stay in business?
We can't do it if it's going to be based on volume. And I've heard people say, listen, that's the reality. We get, even when you're cost-based, in a sense, you've got a lot of your business that's based on volume. And as long as payment is based on volume, to ask an already low-volume provider to cut more fat out of the system is going to be extremely hard. So we've got to look at a different way of paying for it that is not volume-based, but that is based on outcomes, based on value. And I just happen to be biased enough to believe that rural providers they know about value, and they know how to provide value. A lot of the things that we do as rural providers are driven by the way we get paid, not by the way to do something right or the way to do it better, but we're forced by the way we get paid to do it the way we are. I'm not, I mean, there's a lot of apprehension and there's a lot of concern, and your question reflected that. But I believe we can do it. Some of the most flexible, responsive people that I know are the people that have had to learn to be that way, and they're the small rural providers. And, so I think as the system aligns and moves from volume to value, I think rural providers have a story to tell, and as I said in the slide, I see them finding sustainability through value. But you're right, we can't do it under the current payment mechanism.
Mm-hmm. Any other questions? Looks like Kathy is typing a bit. Paul, can you tell us again where we can get a look at that NQF report and how we can give our thoughts on it?
I tell you, it's as simple. If you can go to the NQF, National Quality Forum website. It's www.qualityforum.org. And then the rural part that I talked about, just put /rural health, and it'll take you to it, and there's probably even a link on their website. I don't have it in front of me right now, but I don't think it would be hard to find it. And then their email, if you want, I think you can actually get on email alerts where NQF is sending you out email alerts that let you know when this rural health thing is happening. But their email address is ruralhealth@qualityforum.org. And I know I've talked to the project team. They're excited about this project. They recognize the challenges that, this has really gotten them in neck deep into this. And they recognize the challenges that are facing rural providers in finding